focusing on an organ that I think for most of us we successfully ignore for 99% of our lives. Yeah. It just sits there quietly doing its job right up until the moment it decides to try and kill us.
And it creates quite a scene when it does. It really is one of the most dramatic presentations in internal medicine.
We are talking about the pancreas. And honestly, reading through the source material for this dive, the phrase that just kept looping in my head was body horror.
It is visceral, isn't it?
Because the condition we're discussing, pancreatitis, is essentially a story about an organ that starts to eat itself.
Autodigestion is the medical term, but it really doesn't capture the violence of what's happening at a cellular level.
Right.
It's not like inflammation in a swollen ankle. This is a chemical burn from the inside out.
That is the hook right there, autodigestion. So our mission today is to unpack exactly how this happens. We need to understand what happens when this digestive factory goes rogue.
Yeah.
But before we get into the gore, and there is plenty of it, we need to set the stage, because we aren't just talking about one disease here. This thing has two very different faces: acute pancreatitis and chronic pancreatitis. Can you give us the high-level distinction before we zoom in?
Of course. Think of them as two different timelines with drastically different states. Acute pancreatitis it's an explosion. It is a sudden, chaotic event. You have this immediate onset of upper abdominal pain, your enzymes spike, and it is a full-blown medical emergency. But, and this is crucial, for many people, it's reversible.
The storm passes.
The storm passes and the city can rebuild.
Okay, so that's the hurricane.
Exactly. Then you have chronic pancreatitis, and this isn't a storm, this is climate change.
Oh, wow.
It's a progressive, irreversible disease. It's the result of long-standing inflammation that eventually leads to the permanent destruction of the organ. So you aren't just dealing with a one-time flare-up. You are looking at the slow, agonizing loss of function. The pancreas eventually stops being able to do its two main jobs, digesting your food and regulating your blood sugar.
So one is a bomb going off, and the other is a building slowly crumbling into dust over years.
That is the grim reality, yes.
Let's start with the bomb then. Let's dive into the acute attack. The pathophysiology here is fascinating because it seems like a major design flaw. How does this self-digestion actually trigger?
Right.
Because usually the pancreas makes enzymes to digest my lunch, not my own tissues.
So to understand the failure, you have to appreciate the safety mechanism. Under normal circumstances, the pancreas is a fortress. It creates these powerful enzymes like trypsinogen in an inactive form.
Yeah.
They're just potential energy harmlessly stored in granules waiting to be deployed. They're supposed to travel down the pancreatic duct, exit into the small intestine, and only then, when they hit the gut, do they get activated into trypsin.
Okay, I like that. So the grenade has the pin in it while it's in the bunker. It's only supposed to be pulled once it's safely out on the battlefield of the intestine.
That's a great way to visualize it.
Yeah.
But in acute pancreatitis, the pin gets pulled while the grenade is still in the bunker.
Oh.
For various reasons, that trypsinogen gets activated into trypsin inside the pancreatic cells. And once trypsin is active, it's not just one grenade going off, it triggers a chain reaction.
It wakes up the whole arsenal.
It absolutely does. Trypsin starts activating all the other digestive enzymes stored nearby.
And that's where the real damage starts.
It is. And while trypsin is bad, the real villain in this horror story is often an enzyme called lipase. When lipase gets activated and is loose in the abdominal cavity, it targets fat cells.
Oh, wow.
It literally breaks down the fat surrounding the pancreas. And this process produces these noxious substances that cause even more injury to the pancreas and the surrounding tissue.
I saw the term necrosis used a lot in the research. That's actual tissue death, right? We aren't just talking about irritation here.
No, not at all. We are talking about death. The enzymes digest the pancreatic tissue itself. They liquefy the surrounding fat, and they can even dissolve the vascular endothelium.
The lining of the blood vessels.
The lining of your blood vessels, yes. This causes bleeding into the organ. It is a battlefield, but here is where it gets really dangerous. It doesn't just stay in the abdomen.
Right. This was the part that blew my mind. You have an organ in your belly that's on fire, but the patient can die from lung failure or kidney failure.
Exactly.
This is SIRS, right? Systemic inflammatory response syndrome.
This is the critical concept. So imagine you call the police for a noise complaint at a house party, but instead of sending a patrol car, they send a SWAT team, the National Guard, and an airstrike.
Total overreaction.
It's a massive overreaction. The injured cells in the pancreas scream for help by releasing cytokines. These are chemical distress signals. And they call in the immune system's heavy hitters, neutrophils and macrophages.
But the response is just too big.
It's huge. It spreads inflammation through the whole body. Those chemical signals make blood vessels everywhere in your lungs, in your kidneys, leaky. Fluid just floods out of the vessels and into the tissues. So your lungs fill with fluid, leading to respiratory distress. Your kidneys lose their blood supply and they shut down.
So a local chemical spill in the pancreas essentially tricks the immune system into attacking the entire body.
You've got it. It is a systemic catastrophe initiated by a local accident.
Okay, that is sufficiently terrifying. So what causes this? Who is pulling the pin on the grenade inside the bunker?
Well, if you look at the data in the United States, the vast majority of cases come down to the big two.
The big two.
Gallstones and alcohol abuse.
Let's break those down.
Yeah.
Gallstones feels like a plumbing issue.
It is exactly that. So the pancreatic duct and the bile duct usually merge right before they enter the intestine. If a gallstone travels down from the gallbladder and gets stuck at that junction, it creates a dam.
Okay.
The pancreatic juices can't get out, pressure builds up, enzymes back up, and the cells can rupture.
Like putting a potato in a tailpipe.
And the engine explodes. Yes.
Now, alcohol, that feels more chemical.
Yeah.
How does a night of heavy drinking trigger this?
It's complex and it's pretty sinister. Alcohol doesn't just block a duct, it actually alters the metabolism of the pancreatic cells.
Okay.
It makes them more sensitive to those activation signals we talked about. It also thickens the pancreatic secretions. It increases the protein content. And these proteins can basically turn into solid plugs inside the tiny ducts of the pancreas.
So you're clogging the plumbing from the inside while simultaneously making the cells hypersensitive to exploding.
Precisely. And it's not always the chronic alcoholic. Sometimes a massive binge can trigger an acute attack, though chronic use is definitely the bigger risk factor.
And beyond the big two.
Outside of the big two, you have a solid chunk of cases, maybe 10 to 20%, where we just can't find a cause. We call that idiopathic.
We don't know.
We don't know yet, yeah.
I have to bring up the medications. I was looking at the table of drugs associated with acute pancreatitis, and it was startling. You know, we think of this as a disease of lifestyle drinking and diet, but there are common prescriptions on this list.
It is a long list, and it's categorized by the strength of the evidence. The Class I drugs have a definite, proven association.
I wrote some of these down because they are in everyone's medicine cabinet. Acetaminophen Tylenol.
In overdose scenarios, yes, it's a major toxin.
Furosemide Lasix, the water pill for heart failure. Estrogens, opiates, which is kind of ironic because we use them to treat the pain, and valproic acid, which is for seizures and mood disorders.
It's frightening, isn't it? And then Class 2 includes metformin, the most common diabetes drug in the world, and corticosteroids.
And even ibuprofen is on the list of possibles.
Class 3, yeah. Ibuprofen and sertraline Zoloft. The list is long.
But here's the thing that confuses me. If these are definite associations, why does the medical community seem hesitant to blame the drugs in a specific patient? The research notes that it's really hard to prove causation.
Right. Think about the ethics of that proof. To scientifically prove a drug caused the pancreatitis, you would have to stop the drug, wait for the patient to recover, and then re-challenge them.
Give them the drug again.
Give them the drug again to see if the organ explodes a second time.
Here, take this pill and let's see if you end up in the ICU again.
Exactly. No doctor's going to do that, and no patient would consent to it. So we are left with case reports and patterns. We know Tylenol can do it, but proving it did it to you specifically without a re-challenge is mostly deduction.
Okay, so we have the mechanism of the grenade, and we have the culprits. Now let's talk about the experience. What does it look like when a patient walks or probably crawls into the ER? How do you recognize the storm?
The pain is the hallmark. And it is not subtle. Patients often describe it as the worst pain of their lives. It's located in the epigastrium, that's the upper middle abdomen, right below the rib cage. But the specific description you hear over and over is boring.
And we don't mean tedious, we mean like a drill bit.
Correct. It feels like a hot poker is being bored straight through your stomach and out your back.
Right.
It comes on suddenly, reaches peak intensity within 30 minutes, and then it just stays there. It is unrelenting.
Wow.
And because of that intense pain and the proximity to the stomach, the body reacts violently. 85% of patients will have nausea and vomiting.
But the vomiting doesn't help the pain, does it?
No. And that's a key differentiator from something like food poisoning. In food poisoning, you vomit and you might feel a bit better.
Right.
In pancreatitis, you vomit and the pain is still drilling a hole through your back.
So you have this excruciating pain, you're retching, you go to the hospital.
Yeah.
How does the doctor confirm it? I saw something called the rule of 3.
Yeah, and time is of the essence here. We have a diagnostic window of roughly 48 hours to catch the chemical spikes. The rule of 3 refers to the lab tests. We look at 2 enzymes in the blood, amylase and lipase.
Okay.
For a confident diagnosis, these levels shouldn't just be high. They need to be at least 3 times the upper limit of normal.
So if normal is 100, we need to see 300. We aren't looking for subtle elevations.
Exactly. We are looking for a chemical spill. But these 2 enzymes have different personalities. Amylase is the sprinter. It rises fast within 4 to 8 hours, peaks at 24 hours, and then drops back to normal relatively quickly.
Okay.
Lipase is the marathon runner. It rises along with amylase, but it's more specific to the pancreas, and crucially, it stays elevated longer.
Oh, so that's helpful if someone waits to come in.
Exactly. If a patient tries to tough it out at home and comes in 3 days later, the amylase might have washed out, but the lipase will still be waving the red flag.
And once you have the enzymes, you usually confirm with imaging.
Yes. A contrast-enhanced CT scan is the gold standard. It allows us to see the battlefield, we can see the swelling, the inflammation, and most importantly, we can see if there is necrosis, dead tissue.
How does it show that?
Because dead tissue doesn't take up the contrast dye, it shows up as a dark void on the scan.
Speaking of voids and bad signs, let's talk about predicting severity. Most people survive this, but some don't. The research points to a few lab values that act like crystal balls. The one that stuck out to me was hematocrit.
This is a classic teaching point. Hematocrit measures the percentage of your blood that is made up of red blood cells.
So a higher number means more red blood cells.
Technically, yes, but in this context, it's a trick. Think of your blood like tomato soup. You have the liquid broth and the solid tomatoes. If you boil the soup and the liquid evaporates, the soup gets thicker, right?
Okay.
You didn't add more tomatoes, you just lost the liquid.
Yeah, I follow.
In severe pancreatitis, remember that leaky vessel concept we talked about?
Yeah.
The liquid part of the blood leaks out of the vessels and into the tissues. We call that third spacing. So the blood that is left inside the vessels becomes thick and sludgy. The hematocrit shoots up.
So a high hematocrit means the patient is dehydrated and leaking fluid internally.
Exactly. If the hematocrit is greater than 47% on admission, it's a screaming siren that the patient is hemoconcentrated and severe disease is likely.
And if it's lower?
Conversely, if it's lower, say under 44%, it suggests they are handling the fluid status better and the disease is probably milder.
There was another marker that felt like something out of a chemistry lab. Calcium, specifically low calcium.
Hypocalcemia. This is one of the darkest signs in pancreatitis.
Why does the calcium drop?
Remember the lipase, the enzyme that digests fat?
Yeah.
When it breaks down the fat around the pancreas, it releases fatty acids. These acids are sticky. They bind with the calcium in the bloodstream. It's a chemical process called saponification.
Saponification? Wait, that's literally soap making.
It is. The body is effectively manufacturing soap in the abdomen out of its own fat and calcium.
That is horrific.
It consumes the calcium from the blood. So if we draw blood and see the calcium levels tanking, we know it's because it is being used up in this massive necrotic process inside the belly. It's a direct proxy for how much tissue death is occurring.
Okay, let's move to saving the patient. We've diagnosed them. We see the soap making. We know the blood is turning to sludge. What is the game plan?
The goals are actually very primal. Relieve the pain, refill the tank, and stop the infection.
Let's talk fluids first. You mentioned the sludge blood. I assume we need to pump them full of liquids.
We do. The guidelines call for rapid replacement. The patient is essentially in shock. They are dilated, they are vomiting, they are leaking, they are hypovolemic.
Is there a magic number? Give 5 liters stat.
You'd think so, but this is where medicine becomes an art. The source material actually admits there is a lack of objective data on the optimal rate. It's a high wire act. Yeah. If you give too little, the kidneys fail because they have no flow. If you give too much, you drown the lungs, which are already leaky. We have to constantly reassess.
Now, pain management. We've established this is boring pain. We aren't giving them an Advil and a pat on the back.
No. Opioids are the standard. Morphine is the workhorse here. In fact, for patients who need constant relief, we often use patient-controlled analgesia, or PCA.
The button they can push.
That's the pump with the button, yeah.
There was a really interesting historical sidebar in the research regarding a drug called meperidine. It seems like the guidance on this has completely flipped.
Oh, absolutely. For decades, medical students were taught, don't use morphine for pancreatitis, use meperidine.
Why?
The theory was that morphine causes spasms in the sphincter of Oddi, that little valve that lets the enzymes out. We thought morphine would clamp it shut and make things worse.
Sounds logical.
It does sound logical, but the data didn't back it up. Worse, meperidine has a metabolite, a breakdown product that accumulates in the body and causes seizures.
So we were trading a theoretical spasm for actual seizures.
That's it, exactly. So the guidelines shifted, meperidine is out, morphine is back in. It's a perfect example of how dogmas in medicine can persist until the evidence finally kills them.
Speaking of dogmas dying, let's talk about food. Nutrition. I always thought the golden rule for pancreatitis was MPO, nothing by mouth. Starve the patient so the pancreas can rest.
Mm-hmm.
If you eat, the pancreas wakes up.
Right. That was the gospel for a long, long time. Rest the gut. But we are looking at it too simply. Acute pancreatitis puts the body in a massive catabolic state.
Meaning it's burning energy like crazy.
Right. It is burning through energy reserves to fight the inflammation. If you starve the patient, you weaken them when they need strength the most.
So starving them makes the fortress easier to breach.
Worse than that, it actually compromises the walls of the fortress. The gut lining needs food to stay healthy. If you don't use the gut, the mucosal barrier starts to atrophy. It thins out.
And what happens when the barrier thins?
The bacteria that live in your colony, coli, and friends see an opening. They can migrate or translocate through the weakened gut wall and move into the abdominal cavity.
Well, they find a buffet.
They find that dead, necrotic pancreatic tissue, which is essentially a warm buffet for bacteria, and they set up shop.
So by not feeding the patient, we were inviting the bacteria to break out of jail and infect the dead tissue.
That's exactly it. So the paradigm has flipped. For mild cases, we say, eat as soon as the pain allows. For severe cases, we prefer enteral feeding.
Tube feedings.
A tube down the nose past the stomach, yes. We prefer that over IV nutrition. We want to keep the gut working to keep the barrier strong.
That leads right into antibiotics. If we are worried about these jailbreak bacteria, shouldn't we just nuke them with antibiotics proactively, just in case?
Again, intuition says yes, data says no. Prophylactic antibiotics, giving them before an infection is proven, have shown no benefit.
Right.
None. They don't prevent death, and they don't prevent surgery. All they do is breed resistant superbugs.
So we wait.
We watch, and we wait. We only treat if we have a confirmed infection or a very strong suspicion. And if we do treat, we have to bring out the big guns. Because the pancreas is deep in the body and filled with dead tissue, we need antibiotics that can penetrate that mess.
Like what?
We use broad-spectrum carbapenems, like meropenem.
Okay, so that's the acute attack. It's a frantic, high-stakes battle to manage fluids, control pain, and prevent that secondary wave of infection.
It is.
But now, I want to turn the page. Because for some people, the storm doesn't just pass. It changes the landscape forever.
Chronic pancreatitis.
Yes, this feels heavier.
It is tragic. Acute pancreatitis is a medical crisis. Chronic pancreatitis is a life sentence. It is a permanent, irreversible alteration of the organ.
The text mentions fibrin deposition. That sounds like scar tissue.
It is. Imagine replacing the complex machinery of a factory with concrete. The functional cells, the ones that make enzymes and insulin, die off and are replaced by fibrous scar tissue.
What drives this? Is it the same culprits as the acute attack?
Mostly. In the West, alcohol is the overwhelming driver, about 70% of cases. And the mechanism is fascinatingly specific. It involves these things called pancreatic stellate cells.
Stellate means star-shaped.
Yes. These star-shaped cells normally sit quietly in the pancreas, doing repair work. But chronic alcohol exposure or oxidative stress wakes them up, and not in a good way. They get angry.
Angry cells.
They transform into myofibroblasts, and they start laying down collagen scar tissue everywhere. They literally choke out the healthy cells.
So the star cells encase the organ in concrete.
A perfect visual. And this leads to the classic presentation, or the triad of symptoms.
Let's walk through the triad. Number one, again, is pain.
But it's a different pain. In acute, it's inflammation. In chronic, it's neuropathic. The nerves themselves are encased in that concrete scarring.
Oh, man.
They are firing continuously. It's deep, penetrating pain that is often worse after eating, which leads to patients developing a fear of food.
That's heartbreaking. Number two is a word that is fun to say, but terrible to experience. Steatorrhea.
Fatty stool.
And this happens because the factory is gone.
Right. If you don't have lipase, you can't digest fat. The fat just passes right through you. But here is the most mind-blowing statistic from the source material.
Go ahead.
The pancreas has an immense reserve capacity. You don't get steatorrhea until enzyme secretion is reduced by 90%.
90%.
90. Think about that redundancy. You can lose 50%, 70%, 85% of your pancreas and still digest your dinner perfectly fine. You wouldn't even know you were sick.
Wow.
But once you cross that 90% threshold, you fall off a cliff. Malabsorption hits. You start losing weight rapidly because you are starving despite eating. You become deficient in fat-soluble vitamins like A, D, E, and K.
And the third part of the triad.
Pancreatic diabetes. This is the late stage. The scarring finally destroys the islet cells, the endocrine part of the pancreas.
The insulin-making cells.
Right. So now you can't digest food and you can't make insulin. You are brittle.
I noticed in the diagnostic section that relying on blood work here is a trap. In acute AP, we look for high enzymes. In chronic CP, the text says enzymes are usually normal.
That is a critical distinction that trips up inexperienced clinicians. In an acute attack, the factory is on fire, so smoke, the enzymes, is everywhere. In chronic disease, the factory has burned down years ago. There's no one left to work. There are no enzymes to leak into the blood, so amylase and lipase are normal.
So how do you find it?
You have to look at the wreckage. You use a CT scan to look for calcification stones within the pancreas, or you test the function. You measure fecal elastase. If there is no elastase in the stool, it proves the pancreas isn't doing its job.
Managing this seems incredibly burdensome. It's not just take a pill and call me in the morning.
No, it's a lifestyle overhaul. Step 1 is absolute abstinence from alcohol and smoking. If you keep drinking, you are pouring gasoline on the smoldering embers. It just accelerates the pain and the failure.
Then there is the pain management, the ladder approach.
Yeah, we try to avoid the heavy opioids if we can because addiction is a huge risk in chronic pain patients. We start with Tylenol or NSAIDs before meals. We use low-potency opioids like tramadol, and we often use drugs like pregabalin, which treats nerve pain since we know the nerves are damaged.
But the part that really struck me was the enzyme replacement therapy. Treating the malabsorption. The pill burden here is insane.
It is massive. To digest a meal without a pancreas, you need to swallow the enzymes manually. We're talking about 25,000 to 40,000 units of lipase with every meal.
Is that one pill?
No. Usually it's 3, 4, sometimes 5 large capsules, and you have to take them with snacks too.
So a patient might be taking 20 huge pills a day just to be able to eat.
Easily. And they aren't cheap. These are complex drugs brands like Creon or Zenpep. They are enteric-coated microspheres designed to survive the stomach acid.
That was the other nuance, the acid. The text mentioned adding a PPI, a stomach acid blocker, to help the enzymes work.
Right. Enzymes are proteins. If you dump them into a bath of strong stomach acid, they denature. They fall apart before they can work. By lowering the acid with a PPI, you give the artificial enzymes a fighting chance to reach the intestine intact.
It really paints a picture of a difficult life. You are in pain, you are diabetic, you are taking handfuls of pills every time you eat, and you can't have a drink to take the edge off.
It is a relentless disease. It wears people down physically and psychologically.
So let's bring this back to the listener. We've gone from the explosive soap-making emergency of the acute attack to the concrete scarring grind of the chronic condition. What is the takeaway here?
For me, it's a newfound respect for the fragility of the system. We take digestion for granted, but it's a chemical high-wire act. And looking at that medication list, Tylenol, diuretics, it's a reminder that everything we put in our bodies has a cost.
And the importance of not being a hero with abdominal pain.
Absolutely. That 48-hour window in acute pancreatitis is real. If you have that boring pain going through to your back, don't sleep on it. You need fluids, and you need them fast.
I want to end on that 90% threshold you mentioned.
Yes. To me, that is the most profound philosophical insight in this whole chapter.
The idea that you could be 89% broken and feel fine.
Exactly. The body has this incredible silent redundancy. It fights to keep you normal. It masks the damage. But that mask is also dangerous.
Why?
Because it means by the time you actually see the symptoms, by the time you see the steatorrhea or the diabetes, the reserve is gone. The war is already lost.
It makes you wonder what else is happening silently right now.
It does. How many other organs are running at 50% capacity, compensating, holding the line, just waiting for that one final stressor to push them over the edge? We are walking around with hidden damage, protected only by our reserves.
That is a thought that will keep me up tonight. Thank you for that sobering perspective. And thank you all for listening to this deep dive into the pancreas. Take care of your engines, and we will see you next time.